Again, a very good day, my dear postgraduate students. I would like to have a lot of feedback from you people regarding the bone marrow aspiration classes. Today, it shall be on aplastic anemia. And remember, I am not taking the theory part of it. Class 6, aplastic anemia for postgraduates. Always, you people should be able to define, describe, and enumerate. So a definition, what is an aplastic anemia? Literally speaking, there is no proliferation at all. And what are the other related terms in it? For example, hypoplasia. Sometimes we will not give a diagnosis of aplastic anemia, but a hypoplastic map. Pancytopenia, maturation arrest. These are all certain terms which we should know. What is a peripheral smear? The hemogram, how do you define in a case of a pancytopenia? What do you see in a bone marrow smear? How does it differ from a bone marrow biopsy? What are the causes and the mechanisms? And incidentally, what does this word dry tap mean? So these are certain things which we should be knowing. Aplastic anemia, basically the classification of it can be primary. Most of the disorders you find that there will be primary, which means the cause is known. Secondary or primary can be basically a stem cell disorder also. Secondary, it can be because of chemicals such as benzene, insecticide, paint, varnishes, glue, or solvents. Drugs, cytotoxic drugs, obviously, they will be causing suppression of the bone marrow. Antibiotics, chloramphenicol is a very notorious example. Non-steroidal anti-inflammatory drugs. INH again used in the case of tuberculosis. Anticonvulsants, phenytoin sodium, gold salts. These are all some drugs. There may be many more which you people can come across. Radiation exposure. Obviously, there will be a suppression of the marrow. Basically, because of a stem cell or a committed stem cell defect. Viruses. COVID, it was a very unpleasant experience we had during the last 2 years, the COVID-19. Epstein-Barr virus, non-A, non-B hepatitis, HIV. So any of the viral infections, initially there will be an aplasia and then a pancytopenia. Progressively, the patient will be recovering. Immune and rheumatological, it can be a graft versus host disease, rheumatoid arthritis, SLE, etc. Paroxysmal nocturnal hemoglobinuria. Pregnancy, strangely, this also can have an aplasia. So this is some of the causes for aplastic anemia. Pancytopenia, on the contrary, is a little different. It means the patient's hemoglobin is less than 10 grams, WBC is less than 4,000, then absolute neutrophil count is less than 1,500 per microliter, and platelets less than 1.5 lakhs. This is the book definition, but of course, we are commonly seeing values lesser than this. Pancytopenia and aplasia need not always be the same. So here, I am finding aplastic anemia as one of the causes. Then there can be bone marrow infiltration by hematological malignancies, non-hematological metastasis, storage disorders, Gaucher's, etc. Osteopetrosis, the marble bone disease, myelofibrosis. So this is the bone marrow infiltration. I do not find the normal marrow elements, or these are being replaced by the foreign elements. Paroxysmal nocturnal hemoglobinuria. This is one condition where there might be a cellular marrow, but at the same time, I find that there is a hemolysis. Hypersplenism. There is a destruction outside. Myelodysplastic syndrome. We shall be seeing this shortly. Megaloblastic anemia. It can be a type of a hemolytic anemia, but then in megaloblastic, I find that there is a DNA defect. Therefore, there can be suppression of all the three elements. SLE, we had seen, cytotoxic drugs, antimetabolites, radiotherapy, overwhelming infections, and others. So this is a list for pancytopenia, and these are the demarcating features. Again, the bone marrow, I have already told you people what are all the headings to follow. In this one, I am finding lot of these empty spaces, the fat spaces. Of course, it is a marrow one because I am finding some cells which are not seen in the peripheral blood. Now, in aplastic anemia, you are not going to make a cellular diagnosis, but then you should comment on the cellularity, which means 100 minus the age of the patient. If the patient is 30 years old, that should be 70% cellularity. Gross appearance of the marrow. Normally, a marrow will be reddish brown in color, but the more it is being replaced by fat, it will take up an yellowish tinge. So that will be what you people see in a biopsy. The cells again, this is important. Always we'll have to do a differential count. In this case, there is going to be a suppression of erythropoiesis, leukopoiesis, megakaryopoiesis. But then what else is left? There can be a relative remnant of the lymphocytes and plasma cells which are increased. But then when we do a count, we count the myeloid cells. And when you do a myeloid erythroid ratio, I find that both myeloid and erythroid are both reduced. Therefore, the ratio is not affected. Thanks to American Society of Hematology for this picture. So the terms that we will have to remember when we report on a aplastic or a hypoplastic marrow will be whether it is hypocellular or acellular. You will have to follow the bone marrow particle trails and also look for a pancytopenia in the peripheral blood. Sometimes there is bicytopenia. Instead of 3 elements, I find only 2 are getting reduced. The third one is not. Pure red cell aplasia. Here only one is getting affected. This I shall be seeing in a separate class. Dry tap. So obviously you try to aspirate, you don't get any material. This can happen in a case of a aplastic anemia. But a contradictory experiences, sometimes a hypercellular marrow can also lead to a dry tap because too many cells come and block the needle. You'll have to withdraw and go in a different direction. Cellularity, which is markedly reduced. And differential count, as I told you, you will find fewer of the normal cells and it will be replaced by relative replacement by lymphocytes and plasma cells. So these are some terms which we should remember. Look at this. Obviously, it is hypocellular. I am finding too many of the fat spaces. Maybe here and there I can find some precursor or a megakaryocyte if I am lucky. Generally, even that is not seen. But the moment it is, you can boldly report a hypocellular marrow. But a biopsy is always better. So compared with this, I find that there is a straightforward ratio between the cellularity in some regions and then there is a vivid stretch of fat. So I think the cellularity is less than even 10% in this case. A bone marrow biopsy would suffice. Thanks to British education for these pictures. How do you report on this? Always the biopsy counterpart should be bone in mind. Biopsy is also there, then a bone marrow smear is also there. Simultaneously, a hematogram or a hemogram will be mandatory. I should know all the other values. Complete clinical and treatment history. When I say a hemogram, this must be simultaneous. It should not be taken on a different day and the bone marrow aspiration on another day. And a provisional diagnosis should also be there. For example, the patient is in failure or there has been a severe viral infection, something should be there. So, coming to pancytopenia, beautiful picture, but still I can make a diagnosis of pancytopenia. One, because the RBCs are getting separated. So, though I cannot judge the RBC count, they are being separated even at the junction of the body and tail. So, it means it is reduced. And secondly, I'm not finding any leukocytes or they will be markedly reduced. Platelets are also reduced. Therefore, it is a pancytopenia. The features are these: hemoglobin less than 10, WBC less than 4,000, absolute neutrophil less than 1,500, platelets less than 1.5 lakhs. And these are the features of pancytopenia. I would like you to go through. Sometimes judgment matters. Look at this smear. Here again there is a dispersal of the RBCs, but the arrow is pointing towards a purplish cell. There is no nucleus. It is a polychromatic cell, which means the marrow is trying to somewhat compensate. But still, when you do a count, you find that the patient is having a pancytopenia or the lineages are being reduced. So judgment always matters. The pancytopenia can be because of the decreased production, as in the case of aplastic anemia. Or two, there can be an increased destruction, as in the case of a viral infection, or it can be because of a hypersplenism, exposure to radiation, etc. So these are certain things I should have in mind: decreased production or increased destruction. So this is a wonderful flow diagram of the pancytopenia thanks to Ewing. I would like you people to kindly memorize. At one end, I am finding decreased hematopoietic stem cell. It can be because of aplasia, myelodysplasia, bone marrow necrosis, sclerosis, myelothosis, some other neoplasia that is infiltrating. Or it can be because of increased hematopoietic cell production, but at the same time, there is a destruction outside. Sepsis, any immunological disorder, hemophagocytic one, hypersplenism, and also these other features are. So I should have these in mind, and you can answer a question of both pancytopenia as well as identify a slide of aplastic anemia. So this is all you people will have to remember. So all the subheadings always need not be significant. You can choose whatever is important. For example, in a biopsy, what are the gross appearance? Then the cellularity, hematopoiesis, erythropoiesis, leukopoiesis. One word is sufficient. All the three lineages are being suppressed. Megakaryopoiesis is being suppressed. Lymphocytes and plasma cells are relatively increased. Differential count, I find that all these are reduced, whereas this is relatively increased. Differential count, and again, myeloid erythroid ratio, not very significant because all the lineages are being reduced. Mitotic activity is absent. And abnormal mitosis, it will happen only when there is a recovery from an aplasia. Iron stores, we can just do it to rule out some amount of aplasia or the hypersplenism. Fibrosis. And what is your comment ultimately? A hypocellular marrow due to this, so it fits in with an aplastic anemia. Any further instruction that you would like to give? So treatment with hematinics and advised bone marrow, particularly a hemogram will do first, and later on a bone marrow if it is required. And finally, a conclusive report. What is it? But this particular order should not be missed. So think of the subheadings and you go through it. It is something like your CAP protocol. To be continued. Thank you.